Hello everyone, hope you're all doing good. In this video, we are going to discuss about the 4th trimester complications. See, there are so many complications that can arise in the postpartum period. So, first let me list out all those things, then we'll discuss one by one, right? Okay. So, there can be subinvolution of uterus, okay? That is, the uterus will not be returning back to its original size. Then there can be late PPH or secondary PPH. There can be chances of postpartum metritis. There can be urinary tract complications as well. Bowel complications can also arise associated with hemorrhoids also sometimes. There can be puerperal pyrexia or puerperal sepsis as well. Obstetric neuropathies, musculoskeletal injuries, psychological disorders. We'll discuss one more syndrome here, that is Sheehan syndrome, right? So, all these can arise as a complication, right? Okay. Cut down my last point, I am not explaining Sheehan syndrome here. We'll see about subinvolution first. Subinvolution can be due to incompletely remodeled spiral arteries, or retained placental fragments, or infection. Clear? So, what happens in this case means there is prolonged lochia or there is increased bleeding as well. When you do a pervaginal examination, the uterus is going to be large and soft, and in the ultrasonogram, you will be able to see subinvolution as well as retained placenta. Let's see what is the difference. So, subinvolution or retained placenta. So, definitely in retained placenta there is going to be thickening of the endometrium, right? So, there is thickening of endometrium and you will may be able to see a endometrial mass as well, right? Whereas in subinvolution, what is going to happen is there is enlarged uterus with tubular hypoechoic areas that is present in the myometrium. So, what is this tubules are going to be? These are nothing but the tubular structures are going to be the neovascularized blood vessels, or there can be the dilation of the normal previous blood vessels also. Clear? Okay. So, how will you manage the subinvolution? You have to give them uterotonics. Okay, you have to give them uterotonics, like you can give them methergin 0.2 milligram orally, that has to be given for every 3 to 4 hours and it should be continued for the next 24 to 48 hours. Clear? Right. Now, we will see the late postpartum hemorrhage. So, late postpartum hemorrhage, as I told you, this is nothing but the secondary PPH, and The definition is it starts after 24 hours after delivery and it may continue up to 12 weeks after delivery. There can be worrisome bleeding, okay, that can happen in 1% of the people, and it can happen in the first 1 to 2 weeks after delivery itself. Clear? And if you ask me what may be the causes of the secondary PPH, means there can be retention of placental fragment, or there can be a uterine artery pseudoaneurysm. There can be abnormal involution of the placental site. So there can be chances of von Willebrand disease also, okay, and then there can be any other inherited coagulopathies. So all these things should be checked if there is a case of secondary PPH, okay. So how you are going to manage? So management, you have to give medical management using methergine or oxytocin or even prostaglandin analog. Clear? And if clots are seen in the uterine cavity, then you have to do a gentle suction and curettage as well. Clear? Right. Now we'll go to the next complication, that is postpartum metritis. See, postpartum metritis can be mostly due to chlamydia trachomatis. So you have to give empirical therapy whatever be the organism. So empirical therapy, and this will be needed for at least around 7 to 10 days. Okay. So you can give empirical therapy using the drugs like azithromycin or doxycycline or amoxiclav, okay, that is amoxicillin clavulanic combination. So azithromycin dose is 500 mg, doxycycline is around 100 mg and amoxiclav is around 875 mg. Clear? Right. Now we'll pass on to the next one, that is urinary tract complications. When we speak about urinary tract complications, already we have seen there is dilatation of the urinary system due to progesterone, and that is going to cause stasis of urine in the urinary system. So that is, after delivery you will be able to see some residual urine, and this residual urine can go for bacterial infection as well. So sometimes there can be chances of symptomatic urinary tract infection. Clear? And you have to know that there can be chances of bladder trauma in case of normal vaginal delivery, and this may be associated with the labor duration. If it is a prolonged labor, then the chance of risk of bladder trauma will have been increased. Clear? Right. And sometimes there can be insensitivity to bladder pressure as well, because there can be over distension of the bladder, or there can be incomplete emptying of the bladder, or there can be increased residual urine volume. Okay. So all these things you have to know. Then you have to know that stress urinary incontinence can also happen in 5% of the women during her puerperal state. Clear? Right. Sometimes the enlarged bladder can be palpated suprapubically, or it can be elevated above fundus or even sometimes above umbilicus. Okay. So, after delivery you have to check the woman if she has voided within 4 hours after delivery. Suppose if she is not voided, then you have to check for two things, okay, simultaneously. Number one, you have to check for hematomas, especially if there is any peritoneal hematoma or any hematoma in the genital tract also by using a speculum, right. Then if any hematoma is present, then it has to be ideally evacuated, right. And then simultaneously, if there is no hematoma, you can keep an ultrasound machine in the labor room itself and you can examine her with ultrasonogram. If the residual urine is more than 200 ml, she should be catheterized for 1 week at least. Then after 1 week, this can be removed. Okay. And again you have to check for the residual urine, and if it is coming less than 200 ml means it can be removed, catheter removed, and this will be the normal range. Okay. But between this period you have to give her a course of antimicrobials. Okay. Right. Next one is, see, we can even have a state of hypoestrogenism during pregnancy. I just want you to add this. So, what happens is, after removal of the placenta, the hormones that are produced by the placenta are going to reduce, and that is going to result in a state of hypoestrogenism, right. So, what happens, the women can experience hot flushes, and suppose if she already had a history of migraine, then she can even have a severe headache after delivery. And the differential diagnosis for this is, always keep in mind about postdural puncture headache as well as preeclampsia or severe hypertension as well. Clear? Right. And then this can be managed with analgesics or oral or systemic narcotics or triptans, namely sumatriptan. Clear? Right. Now, we will see the prolapse also. So, prolapse means you can have either anterior or posterior vaginal wall prolapse. So, usually puerperal procedentia reduces, okay, as the weight lessens with involution. Clear? And as I already told you, there can be chance of hemorrhoids also. Now, why hemorrhoids are seen? Because during term itself, the gravid uterus is going to compress the rectal veins, right? So, compression at term by rectal veins can lead to hemorrhoids, and this can lead to thrombosis also. So, how will be managing this? We can give them stool softness as well as some topical anesthetics as well. Clear? Right. The next one is obstetric neuropathies. This occurs because during pregnancy there is a pressure on the lumbosacral plexus. Okay. So, during pregnancy there is pressure on lumbosacral plexus, and this will be manifesting as intense neuralgia or cramp-like pains that is extending down from one leg, or it may involve both the legs as well. Okay. And then the most common neuropathy that is seen is foot drop, because due to the injury to the lumbosacral plexus, sciatic nerve, or common fibular nerve, right? We will see the risk factors as well. Risk factors for nerve injuries include nulliparity, prolonged second stage of labor, then pushing for a longer duration in a semi-fowler position. Yes? Right. And we'll see about musculoskeletal injuries as well. Musculoskeletal injuries means pain in the pelvic girdle, hips or lower extremities following the stretching or tearing injuries. Okay. MRI can be done to get additional information. There can be septic pyomyositis, such as formation of iliopsoas muscle abscess. Okay. There can be separation of symphysis pubis or any one of the sacroiliac synchondrosis that can lead to pain as well. Okay. And in these conditions, the pain will be acute in onset. Okay. What you have to know is the normal distance of symphysial joint, okay, is 0.4 to 0.5 centimeter, and anytime diastasis means more than 1 centimeter, and treatment you have to give them a conservative management, or you can even advise them a pelvic binder, and if it is more than 4 centimeter, then you have to suggest them to undergo a surgery. Clear? Right. We will see about the bowel complications. In bowel complications, there can be acute colonic pseudo-obstruction sometimes, which is also known as Ogilvie's syndrome. Okay. Right. So what happens in this is, there is massive dilatation of colon in the absence of mechanical obstruction. This can lead to perforation of cecum, and there can be fecal peritonitis as well. So this can be seen in the vaginal or operative vaginal delivery, or even a cesarean section. Clear? So what happens is, there is an imbalance between the sympathetic and parasympathetic system. Okay, in the colon. So what happens is, the patient will have complaints of abdominal pain, and there can be nausea, vomiting, cessation of bowel movements, abdominal distension that can be sometimes accompanied with fever also. So, how you diagnose this? You have to take a X-ray abdomen plane, and if this is suspected, you have to keep the patient NPO, and this should be followed by decompression of stomach by using nasogastric tube, and simultaneously you have maintain her fluid and electrolyte balance as well. Okay, and pharmacological management of this condition can be made by giving IV neostigmine at a dose of 2.5 milligram over 3 to 5 minutes. Okay, and this should be given ideally within 30 minutes. Okay, so if this is given, the condition can get relieved by passage of flatus, and there can be a reduction in abdominal distension as well. Clear? Right. Suppose if there is no response to the pharmacological management, there can be need of surgical decompression. Suppose if there is perforation, okay, then you have to seek a laparotomy, that is requiring bowel resection with creation of stoma. Clear? Right. Now, I want to discuss about one of the most important complications that can arise in puerperal period, deep vein thrombosis and thromboembolism. Okay, so this is very, very important. So, DVT and thromboembolism. See, we already know pregnancy and puerperium both are a state of highly hypercoagulable period, and in that puerperium has more risk when compared to the pregnancy. Okay. So, if you see the risk compared to pregnancy in the puerperal period, the risk can increase anywhere between 2 times to 20 times even. Clear? Okay. So, what happens is you can have a pulmonary thromboembolism also. So, this risk is also higher in pregnancy, that is around 7 to 8 times. Okay. And because there is a reduction in the blood flow velocity in pregnancy and puerperium, especially in the left side more than the right side, the DVT most commonly occurs in the left side. Okay. So, there is also an increased concentration of coagulation factors 1, 7, 8, 9, 10, 12 as well as the von Willebrand factor. Okay. So, there is resistance to the activated protein C and reduction in protein S as well that can attribute to procoagulant factors increase in pregnancy. Clear? So, what are the risk factors for this DVT and thromboembolism? So, risk factors include when the woman is having age above 30 years, she is obese, her parity is more than 4, she has a labor that is lasting for longer durations, maybe after 12, for about 12 hours, and she has a gross varicose veins, or there was a history of preeclampsia in the antenatal period, or if she was immobile after any surgery like cesarean section, or she underwent an emergency cesarean section. Clear? So, usually what are the clinical features that is associated with the DVT means? You will be having unilateral pain, especially in the left side, okay, and this can be associated with fever, tenderness of the leg, and there can be sometimes induration as well as edema. Clear? Right. Now we will see the ultrasound findings, that is the investigation to rule out this. So what you have to do is, you will be doing a duplex and color Doppler. So these are the choice of investigations to confirm the diagnosis, okay, and you can confirm pulmonary thromboembolism with the following symptoms, like there can be dyspnea or tachypnea, chest pain, cough, hemoptysis, hypotension, or tachycardia as well. Okay. Sometimes this can be associated with severe chest pain or sudden collapse. Okay. So what are the signs you can see? Signs may include cyanosis, or there can be jugular venous distension or friction rub. Okay. Now we will see what are the investigations to be done for this condition. So investigations may include chest X-ray, ECG and ABG, that is arterial blood gas analysis, and a D-dimer estimation is also useful in non-pregnant state, whereas in pregnancy you have to do ventilation perfusion scan as a first and primary investigation. Clear? Suppose if the patient has undergone any of these scans, then they should be advised to stop breastfeeding for at least 48 hours, since technetium is going to get excreted through the breast milk. Clear? Yes. Next one is about the management of this condition. So how will you manage this? So management, you have to give them full anticoagulation. Yes, you can give them heparin or low molecular weight heparin, and warfarin can also be safely used in the puerperium, and this can be shifted to warfarin after few days of giving heparin. Okay, you have to check the INR. Okay, if the INR is a normal range, then you can shift back to warfarin. So, however, none of these drugs are contraindicated in breastfeeding. So, prophylactic dose of heparin that you can give is around 5,000 to 10,000 international units every Q12 hour for 7 days, and then you can give enoxaparin for every 24 hours at a dose of 40 milligram subcutaneously. Clear? Yes. Now, we will see about puerperal pyrexia. So, puerperal pyrexia. The definition of puerperal pyrexia is when the temperature is more than or equal to 38 degrees Celsius or 100.4 degree Fahrenheit on any one of 2 days of the first 10 days of puerperium. Okay, and ideally it should be after 24 hours. Okay, so temperature is more than or equal to 38 degrees Celsius or 100.4 degree Fahrenheit on any 2 days after 24 hours after delivery till 10 days of puerperium. Clear? Right. So, what are the causes of puerperal fever or pyrexia? So, causes you have to rule out include uterine infection, there can be abscesses or hematomas, or there can be infection of the wound, okay, maybe an episiotomy wound or a cesarean section wound, or there can be DVT. Just now we have seen pulmonary complications also. For example, if there was a bacterial or a aspiration pneumonia, or there was a urinary tract infection, and breast conditions also, okay, like if she had mastitis or engorgement. Okay, so all these factors should be carefully assessed so that we'll be giving appropriate management, right? Okay. Now, I want to discuss about puerperal sepsis also. So, the risk factors for puerperal sepsis, okay, include low socioeconomic status, there was prolonged rupture of membranes, or there was chorioamnionitis, or there was prolonged labor, operative vaginal delivery was performed, bacterial vaginosis, urinary tract infection, and asymptomatic bacteriuria. So, all these causes can lead to puerperal sepsis. Okay. Now, if we see the organisms that is causing puerperal sepsis, we can group them into aerobic and anaerobic agents. So, aerobic agents may include Streptococcus A, B, and then Enterococcus, whereas anaerobic organisms include Peptococcus, Streptococcus, bacteroids, as well as E. coli, right? Then sometimes this organism, Chlamydia trachomatis, can even cause a late infection. So, what are the clinical features of puerperal sepsis? So, clinical features include symptoms like headache, there can be headache, malaise, nausea, abdominal pain, signs like fever, tachycardia, and the uterus can be larger and tender. Then lochia can be profuse, malodorous. Then you may even have wound site pain. Clear? Right. So, what are the investigations you will do? Investigations, first you have to explore the uterine cavity for any retained products of conception. Okay. Then you can send blood cultures and remember to take swabs from genital tract. Okay. So how you will be managing this case? So treatment includes administration of broad spectrum IV antibiotics, okay, till the patient is afebrile for 24 hours, and this may include ampicillin or clindamycin that can be used along with gentamicin. Okay, sometimes extended spectrum penicillins or cephalosporins may also be used depending upon the sensitivity of the organism. Okay. Suppose if there is no improvement with the antibiotics, you have to look for other causes like there can be parametrial cellulitis or septic thrombophlebitis, or there can be a infected hematoma. Clear? Yes. Last but not the least, we are going to discuss about the psychological disorders that can happen in puerperium. So, psychological disorders. This can arise due to multifactorial causes, and they may include stress, rapid changes in various systems of the body, and there is a feeling of responsibility for childbearing as well. Okay. What happens is there is sudden withdrawal of estrogen, right? So sudden withdrawal of the hormones, not only estrogen, including the progesterone also, following delivery, and there is low levels of free serum tryptophan. Okay. So the risk factors for psychological problems may include undesired pregnancy, low self-esteem, poor emotional support, and if there was a previous history of depression and psychosis. Okay. Now, postpartum psychological disorders can be of three types. Postpartum psychological disorders are of three types. Number one, it can be postpartum blues. So, postpartum blues or postpartum depression or postpartum psychosis. Clear? Right. Now, in postpartum blues, the symptoms which the women can have include sadness, crying, anxiety, there can be irritation. So, most of the times this happens in the first week after delivery itself, and it is seen in 30 to 70% of the mothers, and you have to treat it by just reassurance. Clear? When we come to postpartum depression, here the women will be having a feeling of worthlessness. Okay? She may even complain of fatigue. There will be loss of libido as well, and more negative feelings towards the infant. Okay? Towards the infant. and this arises mostly in the 8 to 20 weeks postpartum period, and it can occur anywhere up to 6 months also. Okay, and this is seen in 13% of the mothers, and for them to treat you have to give some supportive measures along with SSRI. Clear? Right. Then we will see puerperal psychosis. So, in puerperal psychosis, the patient will lose touch with reality. Okay. So, they will become dangerous to themselves as well as newborn. Okay. And this can occur anywhere between 10 to 14 days of parturition, and it is seen in 0.1 to 0.2% of the mothers, and you have to treat them by hospitalizing the mother. Hospitalization is needed. You have to give them antipsychotics as well as reassurance may be needed. Clear? So, this is the difference between the postpartum psychological disorders. So, I hope this video have been helpful to you. So, until we meet in the next video, keep going, take care and happy learning.